Okay, we're going to get started. Just short reviews of the chronic neurological diseases that we have done in class for the group projects. First one will be MS, and it starts on page 1428. As your fellow classmates pointed out, this is a chronic, progressive neurological disorder. And while we do not know exactly what causes it, we believe that someone who is susceptible has where there is an issue, let's say maybe possibly an infection, that causes activation of the T cells. The T cells then attack the immune system, specifically the myelin sheaths or the nerves of the brain and the spinal cord. So what we see here is what would be a normal nerve with an intact myelin sheath versus a very damaged myelin sheath because it has been attacked. When this activation occurs, as you can see, the nerve sheath then cannot conduct as effectively, and a patient develops signs and symptoms of MS. Initially, the myelin sheath repairs itself, and then the signs and symptoms subside. And we said that the patient, or say that the patient is in remission. But as the patient experiences repeated attacks, this damaged myelin sheath does not repair. It becomes scarred, and then there is permanent disability associated with multiple sclerosis. Again, showing a normal nerve fiber with an intact myelin sheath versus a damaged nerve fiber or a scarred myelin sheath. And so this is what you need to think about as someone has repeated exacerbations of multiple sclerosis, and that as we have repeated attacks, the myelin sheath loses its ability to regenerate and eventually damaging the underlying axon. Nerve impulses are disrupted, and then you can have permanent loss of nerve function. Okay, so someone with MS, what type of signs and symptoms do they have? The clinical manifestations are listed on page 1428, that is, in your book. And remember, we're focusing on relapsing, remitting. There are 4 types, but that is the type that we're going to focus on. 85% of the people diagnosed with MS have the relapsing, remitting. And so typically these guys have kind of an insidious or a vague onset, and it usually involves the motor sensory and the cerebellum emotional problems. They often experiencing some kind of sensory loss, maybe diplopia, with visual deficits, some weakness, some types of paresthesia, some vertigo, dysarthria, dysphagia, and fatigue, and especially fatigue that's aggravated by being out in the heat and the humidity. So there's a lot of different signs and symptoms. Those are just some of the more common ones. Diagnostics, unfortunately, again, there is no one test that says, hey, you have multiple sclerosis. And so what they do is they do an MRI, and an MRI, if someone is having an exacerbation, it will show the fact that the myelin sheaths are demyelinating, and that they'll have what we call white plaque lesions. They'll also do an LP. The LP often shows the presence of immunoglobulin G and what we call oligoclonal bands, and they often have abnormal evoked potential responses in which they're delayed. And so what they'll say is, okay, the person must have 2 of the 3 things to be diagnosed. They have to have at least 2 lesions, and they have to have had an attack, usually within the last month. And we have to make sure that we're ruling out everything else. Meds just slow the progression and hopefully decrease the number of attacks. Again, this is a disease that has exacerbations and remissions, and so our goal would be to keep them into remission. We looked at the meds in class on page 1430. We talked about the disease-modifying drugs, and the most popular is the beta interferon. Said that the person would give this to themselves every other day, and a subcure ion injection, and that we would need to make sure that we taught them how to do this. That they would need to watch their white blood cell count and liver enzymes, that we would need to make sure that they understand to report any issues with depression or suicide, and that if they have flu-like symptoms, which are common, that they could take NSAIDs or acetaminophen. We also, this cannot be given in pregnancy. You can use immunosuppressants. Just remember, anytime we give someone immunosuppressants, that we have to watch their CBC, specifically their white blood cell count, their liver enzymes, and also you must avoid these in pregnancy. Drugs used to manage exacerbations are often corticosteroids. We've talked about corticosteroids on several occasions in the classroom. If they're having bladder issues, a lot of times they will give them anticholinergics to help with this. And muscle relaxants are very common because they have a lot of issues with muscle spasticity. Surgery. Surgery would really only be for issues that they're having related to the multiple sclerosis. And so sometimes they will actually do some type of surgery. If, for instance, they're having an issue with spasticity, then they can go in and do some type of electrical stimulation, maybe put in a pump where they would give them some baclofen. But there's no specific type of surgery that would deal with, curing this disease. They need to have ongoing PT, OT, RT, speech therapy. Number one issue for these guys certainly is fatigue. And so we talked a little bit about this in class with fatigue for these guys. And so we need to assess for fatigue, encourage them to have rest periods, tell them to set priorities. What is it that you want to get done for the day? Morning is best usually. They need to know to avoid extremes in temperatures. And there are support groups. They also need to be aware of the fact that there are triggers. And triggers could lead to exacerbations, such as extremes in temperature, infections, pregnancy, and so they need to try to avoid these. Self-care deficits, we need to make sure that this is a person that avoids constipation. They understand that they need to increase their fiber intake and their fluid intake and trying to get regular exercise, and they might actually end up with what we call a flaccid bladder if they get a lesion in the area that controls bladder function. And so this is someone who might eventually have to learn to self-cath. This is just showing you a view of an MRI, and it's actually showing you here how they actually have what we call the white plaque lesions that help diagnose MS. When you're looking at your book, it actually gives a couple of different nursing diagnoses. It talks about impaired physical mobility, which certainly can be a possibility during an exacerbation. So everything that you guys learned about impaired physical mobility would take place in MP1. And I chose fatigue because often if you talk to someone who has MS, they say that they suffer from overwhelming fatigue. And so one thing we want to make sure is that these guys know exactly what might set off an exacerbation. And so we need to make sure that they need to understand lots of times that they need to avoid infection, extremes in temperature, that they need to be diligent about getting a good balance of exercise and rest, minimize caffeine intake, and eat nutritionist meals. They need to have rest periods. Sometimes rest periods don't work, but they need to attempt rest periods. Set priorities. What do they need to get done that day? And that morning is often their best time. And, always make sure that you refer them to self-support groups. There are groups within the community for supportive people who are suffering from multiple sclerosis. Then they can also end up with self-care deficits. So we try to help them to avoid self-care deficits, okay? And so often we're teaching them increase fluid and fiber in their diet so they can avoid constipation. If they actually suffer from urinary retention, then we have to teach them self-catheter methods. We want to teach them to take their meds as prescribed. And so we just need to make sure too that they need to understand, even emotionally, there are going to be a lot of adjustments, and that the disease is unpredictable. And so if they can avoid stressful situations, emotional highs and lows, this may also help with the disease process.